And so when we think about privacy, they may not be worried about something bad in their credit report, but it could really be damaging to them, their family, their community, if a disease status like that got out.
Welcome everyone to our series Hacking COVID-19, brought to you by MedISAL, the Biohacking Village, and the Digital Medicine Society. Today we are joined by Eric Perakslis to talk about preserving privacy and ethics in research during an outbreak. Eric, thank you so much for joining us. I'll ask you to start by introducing yourself and then sharing your wisdom.
Sure. Thanks for having me. Hey, everybody, I'm Eric. A little bit about my background. I'm a researcher by training, engineering, master's and undergrad, and my doctoral work was actually in oral protein delivery and drug delivery. Spent about 15 years in pharma. I was with FDA for a few years, as well as helped found a Department of Biomedical Informatics at Harvard Medical School and a few other type things. And I'm currently a Rubenstein Fellow at Duke. I've also had the chance to do a lot of humanitarian work over the years, including crisis response, in particular the last two Ebola outbreaks, the one in West Africa in 2014 and 15, and then the one in Democratic Republic of Congo, more recently. I often get asked about the idea about, how do you ensure that you're doing good? What's the right way to think about things? How can you act quickly? And I think when you're in a crisis setting or a pandemic setting, you don't have to slow down too much to ask the right questions and ensure they're being answered. There's really only four pillars of medical ethics that we're all taught, right? You're taught to do good. You're taught not to do bad, which is actually different than doing good, of course. And you're taught about justice and you're taught about autonomy. Autonomy is really interesting because that's really the one that comes up, right? Like, can you run clinical trials during an outbreak and can you consent people, right? Can you use data if people are hurt and actually aren't awake or able to answer for themselves? You end up with a lot of tough questions. And the way I was raised through this and the mentors that I observed in the field over the years, the first thing I became aware of is actually there really is the ability to do a lot of harm. Unproven interventions, unproven experiments, even with the best of intentions, can lead to things that really, really, really go wrong. Handing out mosquito nets and vaccines can actually cause problems for people. You wouldn't think simple interventions could, but they actually could, depending upon the political, religious, socioeconomic situation of where you're working. And so you really do have to be careful about that. The bit about the ethics and autonomy, I think, is really, really important because whenever I think about autonomy, I think of a couple things. First of all, I think self-determination, right? That patients really, it is really up to them what happens to them, even if they're very sick. And so if they're conscious, if they have a family member, you should be able to conduct research, even in West Africa, the way we think of it in the West, using informed consent, using these types of things, even if it's verbal, you can record it, right? There's lots of ways to do it. So I'm actually one of these people who doesn't believe there have to be huge trade-offs in crisis situations or in epidemics to do ethical care and research. The other side of the coin here is that you really don't have time to get it perfect, right? So there's no such thing as a perfect consent conversation or perfect privacy. I don't know that those things really exist, and I don't know how useful they would be if they did, but I think it's really important to think maybe from the other angle about, well, instead of wondering what perfect privacy looks like, what am I worried about going wrong? What could happen? There are parts in this country today, having started my training in the 80s in college, my first hospital job, it was during what we called the AIDS epidemic at that time. And there was huge stigma around HIV status. And here it is 30 years later, and there's still huge stigma around HIV status. And so when we think about privacy, they may not be worried about something bad in their credit report, but it could really be damaging to them, their family, their community, if a disease status like that got out. And so you really have to kind of tick off in your mind, what are the things that could go wrong with this intervention? What do I want to make sure doesn't happen? And when I'm trying to make sure what I want to happen, right? So it's just really, really important to think about that. That said, I do have a paper in a journal called Conflict and Health where I talk about, how digital technologies can be used ethically. And I actually do believe that digital technologies in multiple instances can actually guard and protect people better than paper. So an example would be in work that I did in the Middle East, where we were working on things like adoption, and certain religious sects might have caused harm to the mothers if they found out that a mother had put a child up for adoption. And I got really concerned that we would leave all that paper behind us when we left. That after we left, after the mission was closed or something like that, somebody could break down that door, open that paper, and find out who had done what. That worried me, as opposed to being able to lock up a database drive, put it in the hands of somebody right person and be there. So I think, again, there are always benefits and risks, and you should actually be weighing. If it's a study, think about benefit risk. If it's intervention, think about the benefits or risk. And I may be sounding like I'm saying this because it applies to me, but you have to involve some people that have been there, because it's just like too many things that are anecdotal learning. There's just no way that you can just learn everything from books or from hearsay. And there's reasons why, for example, clinicians have to just do thousands of hours of rotations under the supervision, because there's all the different situations going to prop up and there's no way to do it. And I think acting in pandemics, intervention in pandemics is like that. I mean, we see this here today. We see so many things right now in the US. Every time I look at LinkedIn, there's 500 companies that are helping with this and helping with that. And I am 100% sure they all mean well. I'm also 100% sure they all won't end up helping. I'm concerned some of them might end up hurting. I'm sure some of them will end up helping. But, it's kind of like, a pandemic shouldn't be your first rodeo in some of this stuff. You should really, there are great people out there that have done this, and all the NGOs and the World Health Organization and the UN and the CDC, and there are these people out there that understand. So make sure that teams have the right expertise on them to do this stuff. you know, Maybe now pivoting more towards the patient and the individual a little bit like that. I think it's real important to make sure that people get their questions answered, and I think that has to be a respectful and thorough process. There aren't dumb questions. There might be dumb questioners, that aren't respectful or don't have the right sensitive context. But again, tuberculosis status, HIV status. Gender, there's so many things right now where you could cause harm to somebody without knowing it because of the way a box was checked. And I do think that people have the right to say no. I mean, I've been working in open data for decades. I've built open source platforms and given them away for free. And I'll be honest, I'm not one of those people who believes that people should be expected or even forced to donate data to things. I still think it should be personal choice. I do believe it's a good thing to do, just like clinical trial participation. But if an individual does not want to, and they understand what they're being asked, and they decide to say no, society and we have to understand that. Now that said, in pandemics, there is the public health issue, where these things get a little dicey, right? So if you have a communicable disease and you are walking through a supermarket behaving irresponsibly, or spreading it, well, yeah, pandemics are a different situation. We're not allowed in this country to run into a crowded theater and yell fire, right? So it is, so there are certain things so outside of a pandemic, for example, there are certain diseases like types of tuberculosis where if you show up at your emergency room with one of those diseases, they're going to ask you questions on where you've been, and they're going to report it to the state board of health. It's just for epidemiology, just to track it, to make sure that that other people aren't at risk, not because the person that showed up sick is a bad person. They're not a bad person, they're just sick. And I think that's something else that really has to be understood here. I mean, Ebola has a lot of fear and stigma and a lot of things associated with it. And people are just so scared of the horror of that disease. But you know what? If someone has Ebola, they're just sick. You know what I mean? And you got to remember that they're just a sick person. They deserve care. They deserve food. They deserve kindness, right? So it is what it is. And people with the right disposition have to do this work. And I guess that's one of the only other things I'll say is that it's not the type of work for everybody. Just like everything in life, there are certain skill sets that really come in. Staying with the patients for a second, I think that that Don't be afraid to ask questions. Understand that the system isn't necessarily set up for you. And despite all the people that set up the system that really try to do it that way, the fact is it isn't. I mean, you know, when you upgrade your iPhone, the 40-page end user license agreement that you're asked to click on is actually to protect the liability of the company, not to protect your privacy. People know this. And in a medical situation, the patient, if it's you, if you're a caregiver, if it's a parent or a child, or it's one of your parents, whatever it is, get your questions answered and understand that they do need to be respectful of what's going on. At the same time, patients are going to be asked to be compliant. If they ask you to wear a mask, if they ask you to do certain things, then then you've got to do that, because they're asking you that to protect other people just like you, just like your family. I mean, right now, one of the things that people in this country are learning that other lands that have been through pandemics have learned is just the isolation of it. It's not just that you have to stay at home and socially isolate. It's that in an Ebola outbreak, people come and take your family member away, and you don't know if they're alive or dead for weeks until you see them again, right? And so a much more drastic situation. So now we have people that, children that are hospitalized and aren't allowed visitors because of the danger of the visitors, right? So these things are happening everywhere. They're not no longer happening in what people think are more emerging lower middle income countries. They're happening here. They're happening right here in my city of Boston, right now, and so we have to handle them appropriately. Yep.
Perfect. So Eric, that was terrific. And one of the things that stood out to me, and you and I have discussed this offline a little bit, is sort of this question of what could go wrong. And you gave the example of essentially a flag landing on someone's, whether it's a medical record or some other kind of record that suggests that they may have had COVID during this outbreak. For folks who haven't thought about the downstream ramifications of this before, and haven't sort of factored that into risk-benefit analyses around research at this time. Can you be more specific about what the risks are there and potentially how we could mitigate them?
Sure. So that's a great question. So the risks are in these situations are highly contextual to geography and to culture. So for example, I had the opportunity to spend a year ago fall in the largest Rohingya camp in Bangladesh. And the Rohingya, as they were fleeing Myanmar, were targeted for ethnic cleansing. And they were checking in on Facebook with family and friends to let people know they were safe. And that's how they were being tracked by the government, was through that. And so those of us that work in this field understand how simple things can actually end up being tragic. So it's the community, it's the ethnicity, it's where they are in the map, it's the socioeconomics of what's going on. Unfortunately, humans are really good, and Mother Nature are actually really good at coming up with almost an unlimited number of harms. I want to say, unfortunately, it's one of the things that humans might be best at. And so that's why I think you really have to have somebody locally, that local context. So, for example, right now, how we're working on COVID-19 in Louisiana with people that went through Katrina, and how they trust authority, and how they know what they believe about safety, and how well they believe public officials. That type of local stigma and PTSD is going to be really big in how those people respond to interventions. So it's not just other countries; it's here in the U.S. as well. And so I think that's there. But the broader answer to the question would be everything from physical harm, where somebody could actually be hurt for some reason, unfortunately through crime, ethnic cleansing, racial tension, or something like that, through economic harm, through just societal stigma, through being embarrassed or shunned or ostracized because you're a trans gender person, and nobody knew that, and it wasn't their business to know that, but now they do. And so I think that people don't get this. It's really easy to rush in because you're energized and you want to do good, and you're Captain America showing up or something like that, and it's like you really gotta stop, count to 20, talk to somebody who's smart and been there before, think about what can go wrong, and don't be the person that makes the thing go wrong. Literally, I mean, I remember when I first got to Sierra Leone in the first Ebola outbreak. I actually didn't take my hands out of my pockets in my first few days, not because I was scared of getting Ebola, but I felt so clueless. And like if I touched the wrong thing and then I go get coffee, I could get the person across from me sick. I was so keenly aware of how I could cause harm. And so I think it's non-intuitive right now, where everybody wants to help in this terrible pandemic, that someone's information getting out. For a lot of people, they would be hurt by a higher mortgage rate because of their credit rating than somebody knowing their HIV status. But that's that person, that one person, because right now financially they're saving up for their first home and they've been trying forever to do it, right? So you just think about what the harms will be, and there are many.
Eric, that was fantastic and a really sort of complete and also solution-oriented answer. So in just a few minutes with you today, our takeaways, I think, are you've educated us to think carefully about the false dichotomy that you don't have to sacrifice privacy in order to get speed during crises like these. That to do that, we need to think about what could go wrong and specifically focus on local context. That's the sort of the strategy to make good decisions. That there are plenty of experts out there who have experience with pandemics around the world. We don't simply have to rely upon ourselves. Seek out those experts and rely on them to help guide us. For patients specifically, you encourage them to ask questions and to feel comfortable and empowered to do so. And also, I think a really thoughtful remark you made was that isolation is hard. It's always hard. And that's something, with everything else going on, we very much are all in that together. Eric, this was wonderful. We learned a great deal. Thank you for taking time out of your day to join us. And thank you again to everyone at MedISO, the Biohacking Village, and the Digital Medicine Society for making this our series, Hacking COVID-19, possible. Eric, thank you so much. Have a great day.
Thanks for having me.